This video will focus on intra-abdominal pressure with reference to definitions, etiology, investigations, management and complications. The definition. Intra-abdominal pressure is the steady state pressure concealed within the abdominal cavity. Abdominal pressure is usually less than 12 mm mercury, and therefore an elevation of pressure termed abdominal hypertension leads to an increase in pressure. This is graded 1 to 4, 12 to 15, 16 to 20, 21 to 25, greater than 25. Abdominal compartment syndrome is a pressure greater than 20 mm mercury plus end organ dysfunction. The physiological effects from an increase in abdominal pressure are broad. Respiratory. This leads to an elevation of the diaphragm, reduction of FRC, increase in atelectasis, and an increase in VQ mismatch. It may be also more difficult to ventilate the patient due to an increase in pressure required, leading to reduced compliance. Cardiovascular effects: reduced venous return, reduced RV filling, and therefore reduced cardiac output. There may be high ICP. The intra-abdominal effects: reduced flow to the GI tract and the liver, leading to reduced hepatic liver lactate clearance. There may be reduced renal blood flow, reduced GFR, and reduced urine output. The etiology of abdominal hypertension leading to compartment syndrome is varied. This could be due to excess fluid, it could be peritoneal fluid, pus, blood or gas, increased abdominal contents from bowel distension, organ transplant or pancreatitis, or finally abdominal wall pathologies from surgery, the prone position or burn injuries. Intra-abdominal pressure measurements can be achieved directly via a catheter into the abdominal cavity or indirectly via assessment through the bladder or stomach. Now we'll discuss how to indirectly measure the intra-abdominal pressure using a simple catheter and a transducer. Lie the patient flat, clamp the bladder drainage system, and insert a cannula into the needle port on the catheter. Remove the needle from the cannula and attach the transducer. Using the three-way tap and a syringe, infuse 25 ml into the bladder. Zero the system at the mid-axillary line and wait 60 seconds. Then unclamp the drainage system and record the intra-abdominal pressure at the end of expiration, remembering to subtract the 25 ml from the urine output for accurate urine output assessment. The next question is, how do we reduce intra-abdominal pressure? This should be assessed in an ABCDE fashion. However, important points to consider are the following. Ensure adequate sedation and analgesia. Decompress the GI tract with an NG tube and aspirate, plus or minus laxatives if clinically indicated. Optimize ventilation and improve perfusion. This may require boluses of fluid in addition to cardiovascular support. Paralysis may be required in addition to altering the patient's position. The final step will be a decompressive laparotomy as a surgical management option. Please like and subscribe if our content is useful.